In 2017, it was approximated that 1.6 million reported using methamphetamine, of which 964,000 people had reported a methamphetamine use disorder. The drug was first synthesized in 1919 in Japan. During World War II, the drug was used for its stimulating effect to stay alert and focus. Notable use was from the Japanese pilots. When the war ended, Japan had a surplus of supply, which led to a wide range of intravenous abuse in the country. In the US at the time, it was used to treat depression and also prescribed as a weight loss aid. Many people used the drug for non-medical reasons, such as studying for long periods of time and athletic competitions. Rates of abuse peaked by 1960s. The decision was made by the government to restrict and regulate methamphetamine, which made it illegal for most uses in 1971. Today there is only one product on the market called Desoxin, which has limited use in treatment of obesity and attention deficit disorder. Methamphetamine is more potent than amphetamine. The drug can be taken orally, snorted, injected intravenously, or smoked. Methamphetamine users go on binges or runs of repeated IV injections, experiencing recurrent highs. During a run, the drug is approximately injected every 2 hours for a period as long as 3 to 6 days or more. Barbiturates or other depressant drugs are sometimes used either to take the edge off during a run or to assist in sleeping after the binge. The drug can also be combined with heroin to yield a so-called speedball. Methamphetamine is metabolized by the liver and excreted by the kidney. The drug peaks in the bloodstream between 2 to 4 hours. Its half-life is around 10 hours, although if it is taken intravenously, the elimination half-life is just a little over 12 hours. Methamphetamine works by acting on monoamine neurotransmitters such as dopamine, serotonin, and norepinephrine. It binds to the monoamine transporter proteins, which allows it to enter the presynaptic membrane. It then causes the disruption of monoamines in their vesicles, resulting in their release into the synaptic cleft. At very high doses, it can inhibit monoamine oxidase, an enzyme that breaks down monoamines. The combined effect of these processes results in a massive increase in monoamine levels in the synaptic cleft, where they then go on to bind to the postsynaptic neurons. Increased concentration of dopamine in the reward pathway, which includes the nucleus accumbens, ventral tegmental area, and prefrontal cortex. This surge of dopamine in these pathways creates an intense high, pleasure, and exhilaration. The physical high or hyperstimulation is the result of the high concentrations of norepinephrine acting on the brain. As well as the high energy, it also increases the heart rate, blood pressure, and dilates the pupils. Some methamphetamine users who've had an earlier psychotic reaction may undergo spontaneous reoccurrences known as flashbacks. These may be triggered by stressful events. The neurotoxicity was demonstrated when multiple doses of methamphetamine was administered to animals. The results showed long-lasting reduction in the enzyme tyrosine hydroxylase, which is used to synthesize dopamine. Furthermore, damage to dopamine axon and terminals were seen, along with damage to serotonergic fibers in several parts of the brain, including the neocortex, hippocampus, and striatum. Further studies on human methamphetamine users have been done, and the neurotoxicity of the drug have been congruent to prior studies. There appears to be a loss of dopaminergic neurons and fibers during normal human aging. Even a modest amount of damage to this system could predispose the individual to developing Parkinson's disease. Thanks for watching. Don't forget to like, comment, and subscribe.